Welcome to Nexus Clinical. Before diving into this lecture, I want to ensure we're all on the same page. This is for general informational purposes only and does not constitute the practice of medicine, nursing, or other professional healthcare services, including the giving of medical advice. No doctor-patient or pharmacist-patient relationship is formed. Using this information and the materials linked to this content is at the user's risk. This is not intended to substitute for professional medical advice, diagnosis, or treatment. Users should not disregard or delay seeking medical advice for any medical condition they have, and they should consult their healthcare professionals for any such conditions. Clinical experts created the references, content, and clinical insight. NotebookLM, a Google AI tool, created the content, which I extensively reviewed before release. Finally, the host states that he takes all conflicts of interest seriously. Currently, there are no conflicts to disclose. For all of his disclosures and the companies he invests in or advises, he directs users to reach out independently, where he keeps an up-to-date and active list of all disclosures. This overview explores sympathomimetics and their impact on human physiology, a key topic in pharmacy education. It examines agents that mimic sympathetic nervous system effects, causing increased heart rate, blood pressure, and alertness. The content covers effects on cardiovascular, nervous, and renal systems, mechanisms behind complications like arrhythmias, hyperthermia, and kidney injury, a range of sympathomimetics from medications to illicit drugs, challenges in distinguishing sympathomimetic syndrome from similar conditions like ethanol withdrawal and neuroleptic malignant syndrome, management strategies involving benzodiazepines, nitrates, and special considerations for vulnerable groups. We focus on amphetamines, tracing their history, pharmacology, and associated dangers, including derivatives like MDMA, PMA, and bombs. The presentation highlights toxicity management, early recognition, and supportive care crucial for healthcare professionals to prevent adverse effects. A thorough understanding of sympathomimetics and their derivatives is essential. After completing this module, learners should be able to describe the general physiological effects of sympathomimetics, including their impact on heart rate, blood pressure, and alertness, as well as identify common examples. They should also be able to explain the diverse effects of sympathomimetics on different bodily systems, such as cardiovascular complications like abnormal heart rhythms and reduction of blood flow to the heart, as well as central nervous system effects like extremely high fever and seizures. Additionally, learners should understand renal issues such as sudden kidney injury and muscle breakdown. It is important to differentiate sympathomimetic syndrome from other conditions that appear clinically similar, including withdrawal from alcohol and sedative hypnotic drugs, anticholinergic syndrome, heat stroke, neuroleptic malignant syndrome, serotonin syndrome, and overdose of monoamine oxidase inhibitors. Managing toxicity caused by sympathomimetics involves primary strategies, such as the first-line use of benzodiazepines to control agitation and seizures, the use of nitrates to treat cardiovascular effects, and aggressive cooling measures to address extremely high body temperatures. Special considerations should be taken into account when managing patients on beta blockers and in pediatric populations. Furthermore, learners should understand the historical evolution of amphetamine use and abuse, starting from its initial application in medicine to the emergence of designer drugs and the resulting public health challenges. They should be able to compare amphetamine and methamphetamine, noting differences in their chemical structures, central nervous system activity, lipid solubility, and resistance to degradation. It is also necessary to identify various derivatives of amphetamines, such as ecstasy, paramethoxyamphetamine, cathinones, and certain highly potent compounds, and describe their unique pharmacological properties along with associated dangers. Understanding both acute and chronic toxicities related to amphetamines is vital. These toxicities include neurological manifestations like psychosis and seizures, cardiovascular effects such as abnormal heart rhythms and blood vessel inflammation, as well as damage to other organs, including muscle breakdown and heart muscle disease. Finally, evidence-based management strategies for acute intoxication with amphetamines should be known. These include initial assessment, pharmacological interventions such as benzodiazepines and cautious use of antipsychotic medications, and supportive care to manage complications like muscle breakdown. Sympathomimetics stimulate the cardiovascular system, leading to a variety of effects including rapid heart rate, irregular heart rhythms, high blood pressure, and in some cases, low blood pressure, especially in individuals with pre-existing conditions. These effects are caused by the agent's actions on alpha and beta receptors. For example, phenylpropanolamine primarily affects alpha receptors and can cause isolated hypertension accompanied by reflex slowing of the heart rate due to direct stimulation of vascular alpha receptors. In contrast, drugs that predominantly target beta-1 or beta-2 receptors can cause low blood pressure because beta-2 stimulation leads to blood vessel dilation, while beta-1 stimulation enhances heart rate. These drugs can also result in coronary artery ischemia or infarction, which may occur due to increased oxygen demand by the heart that exceeds supply, especially during episodes of high blood pressure and rapid heartbeat. Cocaine, a potent vasoconstrictor, worsens this imbalance and can promote heart attacks or tissue death in the heart by activating platelets and preventing clot dissolution. Long-term use of cocaine may contribute to the development of premature atherosclerosis. Dysrhythmias, or abnormal heart rhythms, are a potentially fatal complication of toxicity caused by sympathomimetics. They can arise through several mechanisms. Beta receptor stimulation increases the automaticity of cardiac cells by facilitating calcium entry and raising the resting membrane potential, which can lead to ectopic beats and dangerous arrhythmias. Some agents, such as cocaine, also influence ion channels in heart cells, altering the duration of electrical action potentials and disrupting normal repolarization. This can trigger early after depolarizations along with a prolonged action potential or prolonged JT interval, which can initiate ventricular tachycardia or a type of life-threatening arrhythmia called torsades de pointes. Damage to the heart muscle from contraction band necrosis may also act as a substrate for arrhythmias and impair the heart's ability to contract effectively. Sympathomimetics are substances that mimic the effects of the sympathetic nervous system, leading to physiological responses such as increased heart rate, elevated blood pressure, dilated pupils, and heightened alertness and energy. These substances can be found in various medications, illicit drugs, and even some everyday products like coffee and energy drinks. Some well-known sympathomimetics include albuterol, amphetamine, cocaine, dextroamphetamine, diethylpropion, dopamine, ephedrine, epinephrine, isoproterenol, ketamine, methylenedioxymethamphetamine, mephedrone, methylenedioxypyrovalerone, metaproterenol, methamphetamine, methylphenidate, midodrine, norepinephrine, pemoline, phendimetrazine, phenmetrazine, phentermine, phenylephrine, phenylpropanolamine, propylhexadrine, pseudoephedrine, ridodrine, terbutaline, and tyramine. Understanding the potential effects and risks associated with sympathomimetics is crucial, especially considering their potential for abuse and overdose. Hyperthermia, or dangerously high body temperature, is an indicator of severe toxicity caused by sympathomimetics. It arises from multiple factors. Drugs such as amphetamines and ecstasy activate the brain's hypothalamic, pituitary axis and stimulate the sympathetic nervous system, increasing circulating levels of catecholamines, cortisol, and thyroid hormones. Increased heat production occurs due to heightened physical activity, such as dancing, and activation of brown fat tissue through alpha-1 and beta-3 receptor stimulation. At the same time, norepinephrine-induced constriction of skin blood vessels impairs heat dissipation. Excessive body heat can result in muscle breakdown, metabolic acidosis, and brain dysfunction. Elevated temperatures have been associated with higher mortality rates and more severe outcomes, particularly among users of ecstasy and methamphetamines. Sympathomimetics affect the central nervous system through various mechanisms. They can cause high fever, alterations in mental status, and seizures. The main noradrenergic nucleus in the brain, the locus coeruleus, projects widely throughout the central nervous system, including the brain cortex, cerebellum, and spinal cord. Stimulating this nucleus releases norepinephrine, leading to widespread activation and excitation of these areas. Indirect-acting sympathomimetics like amphetamines and ecstasy increase overall levels of norepinephrine, which explains the heightened alertness and reduced fatigue experienced by users. The release of dopamine in the brain's reward pathways also contributes to feelings of euphoria, addiction, and craving. Overdosing on these drugs can lead to psychosis, repetitive or compulsive behaviors, heightened agitation, and hallucinations. The kidneys are also affected by sympathomimetics, especially in cases involving overdose. One significant complication is acute kidney injury resulting from rhabdomyolysis, a condition where muscle tissue breaks down and releases myoglobin into the bloodstream. This can damage the kidneys. Multiple mechanisms contribute to kidney injury, including prolonged seizures causing muscle breakdown, overdose-related unconsciousness leading to muscle compression and rhabdomyolysis, and sustained constriction of blood vessels within muscles. Cocaine may also directly exert toxic effects on skeletal muscles. The development of hyperthermia, which can result from central nervous system effects, ambient heat, peripheral vasoconstriction, mitochondrial dysfunction, and prolonged physical activity, further increases the risk of rhabdomyolysis. In rare cases, compartment syndrome has been reported after ingestion of synthetic stimulants known as bath salts. Kidney failure can also occur independently of muscle breakdown, likely due to vasoconstriction of renal blood vessels observed in cocaine use, which can cause ischemia and infarction of kidney tissue. Long-term use of sympathomimetic drugs can lead to persistent high blood pressure and accelerate kidney damage, potentially culminating in renal failure. Sympathomimetic syndrome is challenging to distinguish from numerous other conditions and overdoses. These include alcohol and sedative hypnotic withdrawal, anticholinergic syndrome, complex status epilepticus, heatstroke, hypertensive encephalopathy, hypoglycemia, meningitis, neuroleptic malignant syndrome, serotonin syndrome, monoamine oxidase inhibitor overdose, cyclic antidepressant overdose, pheochromocytoma, sepsis, and thyrotoxicosis. Differentiating sympathomimetic syndrome from some of these conditions can be complex. For instance, alcohol and sedative hypnotic withdrawal may present with signs similar to sympathomimetic syndrome, such as mental status changes and seizures, because withdrawal causes a significant release of catecholamines. Similarly, anticholinergic syndrome may resemble sympathomimetic syndrome but can be distinguished by certain features. Patients with anticholinergic syndrome typically have dry mucous membranes, loss of compensatory sweating, lack of bowel sounds, urinary retention, and flushed skin. Their mental status change also tends to differ. These patients are usually non-focally agitated, whereas those with sympathomimetic syndrome tend to be restless and constantly in motion. Heatstroke is another condition that can mimic sympathomimetic syndrome. Patients with heatstroke often present with a high core body temperature, rapid heartbeat, altered mental status, rapid breathing, and muscular rigidity. While initially they may be sweaty and have elevated blood pressure, heatstroke patients eventually become hypovolemic and hypotensive with dry skin. Multiple organ system failure can then follow. Sympathomimetic syndrome versus neuroleptic malignant syndrome and serotonin syndrome. Neuroleptic malignant syndrome is characterized by dopamine depletion or a central dopamine D2 receptor block. This results in disrupted core temperature regulation leading to hyperthermia, as well as muscle rigidity, increased sympathetic nervous system activity, autonomic instability, and changes in mental status. In contrast, serotonin syndrome is primarily caused by excessive stimulation of the 5-HT2A receptors. There may also be lesser contributions from effects on the 5-HT1A receptors. Serotonin syndrome involves less severe muscle rigidity, but is marked by alterations in mental status, autonomic dysfunction, and neuromuscular abnormalities. These abnormalities include myoclonus, shivering, tremor, and hyperreflexia. Sympathomimetic syndrome and overdose from monoamine oxidase inhibitors are serious conditions that require careful understanding. Overdose of monoamine oxidase inhibitors involves agents that irreversibly inhibit the enzyme monoamine oxidase, leading to an increased availability of biogenic amines in the body. Patients experiencing such an overdose may undergo an initial phase where they show no symptoms. However, this is followed by neuromuscular excitation, heightened sympathetic stimulation, excessive sweating, agitation, elevated body temperature, increased reflex responses, muscle rigidity, tremors, involuntary muscle jerks, and even seizures. In some cases, central nervous system depression, abnormal heart rhythms, and collapse of cardiovascular function can occur subsequently. While monoamine oxidase inhibitor overdose symptoms may resemble those of serotonin syndrome, this condition tends to present with more severe muscle rigidity and a more profound failure of autonomic functions. Sympathomimetic syndrome is a condition that often presents with symptoms such as rapid heartbeat and increased body temperature. It can be distinguished from malignant hyperthermia by the presence of muscle rigidity and sweating. Malignant hyperthermia typically occurs in the context of a family history of similar episodes or exposure to general anesthesia. Differentiating sympathomimetic syndrome from other conditions, such as cyclic antidepressant overdose, pheochromocytoma, sepsis, and overactive thyrotoxicosis, can be facilitated through various diagnostic tests. These may include blood tests, electrocardiograms, computed tomography scans, and toxicological screening to identify the underlying cause more accurately. The treatment of sympathomimetic toxicity primarily involves the use of benzodiazepines as the first-line agent. These medications work by suppressing the release of catecholamines in the central nervous system, which helps to reduce their effects. Benzodiazepines are indicated for managing symptoms such as agitation, seizures, increased psychomotor activity, and hyperthermia caused by excessive muscle activity. Administration should be carried out by rapidly titrating intravenous doses until the patient appears calm. If intravenous access is difficult, intramuscular injections of midazolam can be used as an alternative. Nitrates can be used to manage some sympathomimetic effects such as chest pain, coronary artery vasospasm, and hypertension caused by cocaine. However, in cases of cocaine-induced chest pain, the first line of treatment is a benzodiazepine. Combining alpha and beta blockade, using medications like carvedilol or labetalol, has been shown to be safe in small trials. The American Heart Association recommends these as a second-line treatment for suspected acute coronary syndromes in individuals who use cocaine and methamphetamine after administering nitroglycerin and calcium channel blockers. Nevertheless, until further evidence is available, beta blockers without alpha-adrenergic antagonist activity should be avoided. Alpha antagonism may help reduce severe hyperthermia resulting from toxicity of ecstasy, but it carries risks of overstimulating beta receptors. Tachydysrhythmias, or abnormally fast heart rhythms, usually respond to sedation. However, in some cases, calcium channel blockers may be necessary, though there is lacking consistent evidence to support their use. To control severe hypertension when benzodiazepines and nitroglycerin are ineffective, peripheral alpha-adrenergic antagonists such as phentolamine and central alpha, 2 agonists like dexmedetomidine or clonidine should be considered. Most medications used to treat abnormal heart rhythms should generally be avoided because many sympathomimetic agents, such as cocaine, can affect sodium channels, leading to additive toxicity. In situations where there is widening of the QRS complex or wide complex tachycardias resulting from cocaine use, administering hypertonic sodium bicarbonate should be strongly considered. Additionally, because sympathomimetic agents can promote platelet aggregation, the use of aspirin therapy is recommended for patients experiencing chest pain indicative of cardiac issues. Hyperpyrexia must be treated aggressively with rapid cooling and prevention of muscle hyperactivity. The mortality rate in serotonin toxicity is directly related to the core body temperature, making rapid cooling essential. Although there is limited evidence for an optimal cooling technique specifically for drug-induced hyperthermia, the recommended approach is based on the benefits observed with aggressive cooling in cases of exertional heat stroke. Sedation can help manage hyperpyrexia. However, if the patient presents with rigidity, marked myoclonus, or prolonged seizure activity, paralysis with a non-depolarizing agent may be necessary in addition to sedation. This intervention helps to stop ongoing lactic acidosis and heat production. Psychomotor agitation usually responds well to sedation with a gamma-aminobutyric acidergic agent, such as a benzodiazepine or propofol. Seizures are usually brief and tend to respond to benzodiazepines as well. If seizures persist, an anticonvulsant like phenobarbital, administered initially at a dose of 260 mg intravenously, is recommended. Patients who are taking beta blockers may not display the usual rapid heartbeat that is typically associated with sympathomimetic syndrome. When the sympathomimetic agent has a significant alpha component, the patient may experience severe hypertension due to the unopposed alpha effect. In pediatric patients, the presentation of sympathomimetic toxicity tends to follow a bimodal distribution. Younger children often experience accidental ingestions, which usually result in smaller, self-limited toxic episodes. The treatment for these cases is similar to that used for adults, but medication doses should be adjusted according to the child's weight. Adolescents, on the other hand, are more likely to use larger doses or to combine multiple doses of hallucinogenic stimulants, leading to more intense and longer-lasting toxicity. These patients can present with severe illness, including significant hyperthermia and multi-system organ failure. To improve outcomes, aggressive management is necessary, which includes administering high doses of benzodiazepines, actively cooling the patient externally, and paying meticulous attention to all aspects of care. Amphetamine was first synthesized in 1887, but its significance wasn't recognized until the 1920s. During this time, there were concerns regarding the availability of ephedrine for asthma therapy, leading to efforts to synthesize it. This resulted in the rediscovery of dextroamphetamine in the United States and methamphetamine in Japan. Amphetamine was initially marketed as a nasal decongestant called Benzedrine by Smith, Kline, and French in 1932. Amphetamine tablets became available in 1935 for treating narcolepsy and were promoted as anorexiants, appetite suppressants, in 1938. However, the stimulant and euphoric effects of amphetamine were quickly noticed, and by 1940, abuse was already being reported. This led to the banning of Benzedrine inhalers by the U.S. Food and Drug Administration, FDA, in 1959. World War II played a significant role in the rise of amphetamine use. Both amphetamine and methamphetamine were given to soldiers and prisoners of war as stimulants. This wartime use likely contributed to the sporadic periods of widespread amphetamine use and abuse in the United States from 1950 to the 1970s. During the 1960s and early 1970s, a new wave of amphetamine abuse emerged. Amphetamines like methylene-dioxyamphetamine, MDA, paramethoxyamphetamine, PMA, and paramethoxymethamphetamine, PMMA, became popular as hallucinogens. This led to the Controlled Substance Act of 1970, which classified amphetamines as Schedule II drugs to curb their diversion for non-medicinal purposes, leading to a decline in abuse. However, the 1980s saw the emergence of methylenedioxy derivatives of amphetamine and methamphetamine, which circumvented existing regulations. These included MDMA, ecstasy, and 3,4-methylenedioxyamphetamine, MDA. Since the late 1980s, there has been a resurgence of methamphetamine abuse across the U.S. This resurgence was fueled by the availability of ice, a high-purity, crystalline form of methamphetamine hydrochloride. Methamphetamine-related deaths increased throughout the 1990s and doubled between 2010 and 2014. MDMA gained popularity among college students and teenagers attending rave or techno parties in Europe and the U.S. since the mid-1990s. Other amphetamines, like methcathinone, derived from khat, and 4-bromo, 2,5-methoxyphenylethylamine, 2CB, also found niche popularity in dance clubs in the Midwestern U.S. during the 1990s, though their use wasn't widespread. The continual effort to bypass drug laws has driven the development of newer amphetamines. Synthetic cathinones, marketed as bath salts or legal highs, emerged as a way to circumvent existing laws, leading to serious toxicity and deaths. Additionally, there has been a resurgence in the use of older amphetamines like PMA and PMMA, leading to new cases of toxicity and deaths. The historical context of amphetamine use and abuse highlights the ongoing struggle to balance the medical benefits of these drugs with their potential for abuse and harm. The evolution of amphetamine use from medicinal purposes to recreational abuse, the emergence of new designer drugs, and the ongoing efforts to regulate these substances all contribute to this complex and evolving history. Amphetamines and methamphetamines are both part of a larger family of compounds that share a common phenylethylamine structure. Despite their similarities, methamphetamine has some important differences compared to amphetamine. One of the key distinctions lies in their chemical structures. Methamphetamine is essentially amphetamine with an additional methyl group attached to the terminal amine. Although this modification may appear minor, it results in significant changes in the compound's pharmacological properties. Methamphetamine has a significant advantage over amphetamine due to the presence of an additional methyl group. This structural difference markedly increases its activity within the central nervous system, resulting in a more pronounced stimulant effect on the brain. The methyl group also enhances the lipid solubility of methamphetamine, enabling it to penetrate the blood-brain barrier more rapidly. As a result, the effects of methamphetamine are experienced more quickly and with greater intensity. Methamphetamine has a higher resistance to degradation by the enzyme monoamine oxidase than amphetamine does. Monoamine oxidase is responsible for breaking down neurotransmitters such as dopamine and norepinephrine in the brain. Because methamphetamine resists this enzyme's action more effectively, its effects tend to last longer than those of amphetamine. As a result, the duration of action of methamphetamine is extended, causing its effects to persist for a more extended period. The legal status and medical use of methamphetamine and amphetamine present a stark contrast. Both substances are classified as drugs with a high potential for abuse under the United States regulatory system. However, methamphetamine has limited approved medical applications. It is primarily prescribed under the brand name Desoxin for the short-term treatment of attention deficit hyperactivity disorder and obesity. In comparison, amphetamine has a broader range of medical uses. It is employed to treat conditions such as narcolepsy and attention deficit hyperactivity disorder. Regarding production and availability, the ease of synthesis plays a significant role in the abuse potential of these drugs. Methamphetamine can be produced with relative simplicity, requiring minimal equipment and readily available chemicals. This ease of synthesis greatly contributes to its widespread availability and misuse. The illicit manufacturing of methamphetamine often involves hazardous chemicals, posing serious risks to both producers and the environment. While both amphetamine and methamphetamine share a similar structure and belong to the same class of drugs, the addition of a single methyl group in methamphetamine leads to significant differences in its pharmacological properties, duration of action, and potential for abuse. It is very critical to ensure the understanding these distinctions, particularly in the context of toxicity and public health concerns associated with their use. Many other amphetamine derivatives exist beyond those commonly known. One such compound is 3,4-methylene-dioxymethamphetamine, frequently called MDMA. This substance has a high affinity for serotonin transporters, which leads to the release of large amounts of serotonin. The effects of MDMA include feelings of empathy, euphoria, and sometimes hyponatremia, a drop in sodium levels in the blood. Another group includes paramethoxyamphetamine and paramethoxymethamphetamine. These derivatives are characterized by a single methoxy group. They exhibit strong serotonergic activity, but have poor ability to cross the blood-brain barrier. This results in a delayed onset of effects on the central nervous system, often causing users to take additional doses. Consequently, this practice increases the risk of severe toxicity and even death. Cathinones, commonly known as bath salts, include compounds such as methcathinone, methylene-dioxypyrovalerone, and mephedrone. These substances have a ketone group attached to the beta position, which reduces their ability to cross the blood-brain barrier. Although they exhibit amphetamine-like properties and sympathomimetic effects, they are generally considered less potent. Another notable compound is 2,5-dimethoxy-4-bromoamphetamine, which produces significant hallucinogenic and serotonergic effects. Additionally, there are the 2C series and N2-methoxybenzylphenylethylamines, such as 2C-B and N2-methoxybenzylphenylethylamines. These are potent hallucinogens with varying substitutions on the phenyl ring, contributing to their diverse psychoactive effects. N-methoxybenzylphenethylamines, commonly known as NBOMs, are a class of novel psychoactive substances recognized for their high potency and potential for serious toxicity, which makes them particularly dangerous. These substances are potent agonists of the 5-HT2A receptor and are effective in very small doses measured in micrograms. Their extreme potency increases the risk of accidental overdose, especially since users may underestimate the amount needed to achieve certain effects. Minor variations in dosage can lead to severe, potentially life-threatening consequences. Although bombs can be taken through various routes of administration, their poor oral bioavailability limits their effectiveness when taken orally. This often misleads users into consuming higher doses in an attempt to experience the desired effects, thereby further increasing the risk of overdose. The effects of bombs can take a significant amount of time to appear, and this onset can vary greatly between individuals. Such delayed reactions may cause users to redose, believing the initial dose was ineffective. This behavior heightens the danger of exceeding a safe amount and experiencing severe adverse reactions. As relatively new substances, bombs lack extensive research and comprehensive data about their long-term effects and toxicity profiles. This absence of information makes it difficult for users and medical professionals to predict individual reactions or effectively manage adverse events. Furthermore, bombs are often misrepresented or sold as other drugs like LSD, which can lead to unintentional consumption and unexpected physiological reactions. They may also be found as adulterants in other substances, adding to the risk of unforeseen consequences and making it even more challenging to identify and avoid dangerous exposures. These unique dangers of bombs emphasizes their extreme potency, unpredictable effects, and the limited understanding of their long-term consequences. Their presence in the illicit drug market poses a significant public health concern due to the high risk of overdose and severe adverse reactions. Amphetamines are a broad group of compounds characterized by a shared phenylethylamine chemical structure. They primarily exert their effects by promoting the release of biogenic amines, particularly dopamine and norepinephrine, which leads to a state of heightened sympathetic activity known as a hyperadrenergic state. The specific effects of each amphetamine depend on its selectivity for binding to various neurotransmitter transporters. Acute toxicity from amphetamines mainly impacts the central nervous system and the cardiovascular system. Most of these effects result from an excessive release of catecholamines. In the central nervous system, common symptoms include anxiety, agitation, hallucinations, seizures, dilated pupils, excessive sweating, and increased body temperature. Hyperthermia in this context can occur due to multiple factors such as increased catecholamine levels, heightened metabolic and psychomotor activity, and vasoconstriction that impairs heat dissipation. Notably, psychosis tends to be more prominent after amphetamine use than after cocaine use. Serious brain complications such as bleeding within the brain tissue and strokes have also been reported. In terms of cardiovascular toxicity, amphetamine use can cause high blood pressure, rapid heart rate, and irregular heart rhythms. Reported arrhythmias range from premature ventricular contractions to more severe conditions like ventricular tachycardia and fibrillation. Other vascular complications include reduced blood flow to the heart muscle, resulting in heart attack, dissection of the aorta, and in some cases, acute respiratory distress syndrome and obstetric issues, such as fetal death. Additionally, ischemic colitis can occur. Metabolic disturbances associated with amphetamine toxicity include acid buildup in the body's fluids, muscle breakdown known as rhabdomyolysis, and acute kidney injury. Coagulopathy, or abnormal blood clotting, can also develop, often as a consequence of uncontrolled agitation and hyperthermia. Chronic toxicity from amphetamines and related substances can have severe health consequences. Repeated speed runs, where individuals escalate the amount of amphetamine taken over days or weeks, may lead to acute psychosis that resembles paranoid schizophrenia. Additionally, compulsive and repetitive behaviors such as skin picking, teeth grinding, bruxism, and performing the same tasks repeatedly are commonly reported. Movement disorders like choreoathetoid movements, characterized by irregular jerking or twisting, are also possible. Long-term use can alter the functions of dopamine and serotonin transporters, depleting these neurotransmitters and synapses and causing irreversible neuronal damage. This neuronal toxicity is linked to the generation of oxygen-free radicals, which produce toxic metabolites of dopamine and serotonin, ultimately leading to neuronal destruction. Former users of methamphetamine have shown impairments in memory and psychomotor functions, as well as dysfunction of dopamine transporters and abnormal glucose metabolism. Other chronic toxicities include necrotizing vasculitis of small and medium arteries, affecting multiple organs such as the brain, heart, gastrointestinal tract, and kidneys. This condition can lead to cerebral infarction and hemorrhage, coronary artery disease, pancreatitis, and acute kidney injury. Cardiomyopathy, a disease of the heart muscle, has also been reported. Valvular disease and pulmonary hypertension have been associated with the use of amphetamines for weight loss, possibly due to serotonergic activity. Certain specific amphetamines present unique toxicities. For example, methamphetamine exhibits potent cardiovascular effects. The compound 2,5-dimethoxy-4-bromoamphetamine is known for its significant hallucinogenic and serotonergic effects. MDMA, commonly known as ecstasy, causes a potent release of serotonin and is associated with hyponatremia, a condition characterized by low sodium levels in the blood. Other substances like paramethoxyamphetamine and paramethoxyamphetamine have delayed onset of central nervous system effects due to poor penetration of the blood-brain barrier. This delay can lead users to administer repeated doses, increasing the risk of mortality. The use of cathinones, often marketed as bath salts, is generally less potent than other amphetamines, but they can cause serious health issues such as hyponatremia, compartment syndrome, disseminated intravascular coagulation, acute kidney injury, cardiomyopathy, heart attacks, seizures, and sudden cardiac death. Managing acute toxicity from amphetamines primarily involves supportive care. Careful use of benzodiazepines can help manage some symptoms, while clinicians must also be vigilant for complications such as hyperthermia and muscle breakdown or rhabdomyolysis. The management of acute amphetamine toxicity primarily involves providing supportive care and addressing complications resulting from excessive stimulation of the adrenergic and serotonergic systems. The initial step in management is a rapid assessment of the patient's vital signs, blood glucose levels, and a thorough physical examination. Determining the core body temperature is also essential, as hyperthermia is a common and potentially life-threatening complication. Immediate external cooling measures should be implemented to lower the body's temperature if hyperthermia is present. Patients exhibiting severe agitation and posing a risk of harm to themselves or others may require temporary physical restraints to facilitate pharmacological control. However, it is important to avoid prolonged restraint to prevent rhabdomyolysis and additional heat production. Establishing intravenous access is crucial for administering medications and fluids. If intravenous access proves difficult, intramuscular administration of medications, such as benzodiazepines, can be used until intravenous access is secured. Pharmacological interventions for acute amphetamine toxicity involve several approaches. Benzodiazepines are considered the first-line treatment and are regarded as the primary choice. These medications have a high therapeutic index, effective anti-epileptic properties, and predictable pharmacokinetics, making them suitable for managing agitation, seizures, and other symptoms related to overdose. Typically, diazepam or equivalent drugs are administered intravenously and rapidly titrated until the patient becomes calm. It is important to note that the total dose may exceed 100 milligrams within the first 30 minutes. In addition to benzodiazepines, antipsychotic drugs can be used as adjunct therapy, but with caution. Potent dopamine antagonists such as haloperidol are sometimes considered for managing amphetamine-induced delirium, particularly when benzodiazepines alone are insufficient. However, their use must be carefully considered because these drugs can cause side effects such as lowering the seizure threshold, disrupting temperature regulation, and inducing cardiac arrhythmias. Management of rhabdomyolysis, which can occur due to psychomotor agitation and hyperthermia, requires prompt and effective treatment. Benzodiazepines help reduce muscle activity and heat production, which are critical in this context. Adequate fluid replacement and cardiovascular support are essential to maintain urine output and prevent kidney damage. Although urinary acidification has been suggested to increase the elimination of amphetamines, it is generally not recommended due to the increased risk of acute kidney injury. Supportive measures for managing acute amphetamine toxicity vary depending on the clinical presentation of the patient. Additional supportive care may include oxygen therapy to ensure adequate oxygenation, correction of electrolyte imbalances to restore normal bodily functions, cardiac monitoring along with treatment of any irregular heart rhythms, and mechanical ventilation if respiratory distress occurs. Although urinary acidification can significantly enhance the elimination of amphetamines, such as amphetamine and methamphetamine, by decreasing their half-lives, this practice is not recommended. Manipulating urine pH to increase the excretion of amphetamines does not reduce toxicity and poses a considerable risk of worsening acute kidney injury, which is a potential complication of amphetamine toxicity. This is because acidifying the urine can cause the formation of ferrihemate in the renal tubules, leading to further kidney damage. Specific considerations are necessary in cases involving individuals who have ingested amphetamines in packaging, often referred to as body packers. These patients require management similar to that used for cocaine body packers. Any signs of sympathomimetic symptoms, which may indicate leakage of the drug packets, should prompt surgical intervention. Stabilizing these patients often involves the administration of intravenous fluids, benzodiazepines to alleviate agitation, intubation to assist with breathing, and external cooling measures to manage hyperthermia. Ongoing monitoring and follow-up care are critical components of treatment. Vital signs, mental status, and urine output should be continuously observed to evaluate the patient's response to treatment and to detect any emerging complications. Once the patient's condition stabilizes after the acute episode, it is advisable to conduct a psychiatric assessment and refer the patient for substance abuse treatment to address underlying issues. In managing acute amphetamine toxicity, early recognition and aggressive supportive care are essential. Benzodiazepines serve as the first-line agents for sedation and controlling agitation. The use of antipsychotic medications should be approached with caution and only as an adjunct when necessary. Prompt attention to hyperthermia and rhabdomyolysis is vital to prevent subsequent organ damage. Sympathomimetics are a diverse group of agents that mimic the sympathetic nervous system, leading to widespread physiological effects and significant toxicity. It is crucial to distinguish sympathomimetic syndrome from other toxidromes, such as anticholinergic poisoning, neuroleptic malignant syndrome, and serotonin syndrome, as accurate diagnosis influences treatment strategies. First-line treatment for these conditions involves the use of benzodiazepines, which are essential for managing agitation and seizures by suppressing central nervous system catecholamine release. In cases of cardiac involvement, nitrates are used to relieve chest pain, while the use of beta blockers should be avoided unless they possess alpha-adrenergic blocking activity, especially in acute coronary syndromes. Hyperthermia requires aggressive treatment, including rapid cooling measures. Amphetamines, a notably complex group of substances with a history of abuse, are continually evolving with new derivatives. Methamphetamine, in particular, differs from amphetamine by having a methyl group that increases its potency, lipid solubility, and duration of action. N-benzyloxymethamphetamine, known as N-bomb or NBOMe, are substances with extreme potency. They have unpredictable effects and pose significant overdose risks due to a lack of extensive data on their safety profiles. Management of acute toxicity focuses on supportive care, the use of benzodiazepines, and aggressive management of complications such as hyperthermia and muscle breakdown, known as rhabdomyolysis. It is important to avoid urinary acidification in these cases because it increases the risk of kidney injury, particularly in patients with rhabdomyolysis. This was an episode of the Nexus Clinical Podcast. This is for general informational purposes only and does not constitute the practice of medicine, nursing, or other professional healthcare services, including the giving of medical advice. No doctor-patient or pharmacist-patient relationship is formed. Using this information and the materials linked to this content is at the user's risk. This is not intended to substitute for professional medical advice, diagnosis, or treatment. Users should not disregard or delay seeking medical advice for any medical condition they have. and they should consult their healthcare professionals for any such conditions. Clinical experts created the references, content, and clinical insight. NotebookLM, a Google AI tool, created the content, which I extensively reviewed before release. Finally, the host states that he takes all conflicts of interest seriously. Currently, there are no conflicts to disclose. For all of his disclosures and the companies he invests in or advises, he directs users to reach out independently, where he keeps an up-to-date and active list of all disclosures.